Welcome to tonight's Wu University webinar, Optometry Meets Neurology, Linking Headaches and Dry Eye Symptomatology with Dr. Paul Karpecki.
Oh, jump to the next one.
Thank you. I am your host tonight, Dr. Jennifer Stewart. It is my great pleasure to introduce Dr. Paul Karpecki. If you haven't had the pleasure of speaking, you are in for a great treat. He's the Director of Cornea and External Eye Disease of Kentucky Eye Institute and Associate Professor of the Kentucky College of Optometry, University of Pikeville. Here are his disclosures, and I'm going to turn it over to him.
Thanks, Jen. Great introduction. Great start to everything. You guys are so professional. Everything is so well done. It's an honor to get to speak on this topic. At the same time, it is kind of a unique topic. Normally I do a lot on dry eye. And of course, this does, take into account dry eye. In fact, that's part of the title of today. But we're going to take you through something unique, but it's also incredibly at the heart of our profession. That's what excites me the most about this. So I'm going to share some data that came from EyeSafe. EyeSafe is a company that actually works in the area of preventing kind of blue blocking technology, but they have a lot of data. In fact, if you ever buy those screens that are on your iPhones or on your computers or any of those technologies that filters out some blue light, it's usually from that company. But their data showed that screen time has really soared over the post-pandemic timeframe, which creates a wonderful opportunity to cover this subject matter. And as Jen said, if you have questions throughout, feel free to put them in. I probably only have about 40 minutes worth of material, so an extra 10 minutes of questions would be great. And we're going to take you through, as I said, this fairly unique category that really ties into the whole pain point opportunity that exists within eye care space today. And that's because of digital devices. In fact, the average person spends about 13 hours per day on screens. Now, the data came out in 2021. And of course, that was really at the height of the pandemic. So quite fair to probably say if we saw that data today, it might have gone down to 12 and a half hours. But either way, it's going to be a very significant amount of time. And anytime you see major trends like this, you recognize very quickly that this is an incredible opportunity. Eye strain is the #1 pain point for device users. No surprise there. We would expect that. But I'd like to tie it into the fact that this is in the wheelhouse of optometry. This is the big opportunity. 59% of patients experience symptoms of digital eye strain. 59, more than half, have some level of eye strain. You always think, well, maybe it's 1 out of 5 people. Maybe it's like dry eye. There's 38 million, and that is a huge population. Don't get me wrong. But we're talking 125 million people in the US alone. And eye strain and vision deterioration, depending on how you looked at the survey, were the #1 complaints for device users. So we want to get into that today. But as you remember, the title of this was really tying in headaches, dry eye, and kind of this whole link of how these things work together and how they impact our practice. So we want to get into that. But I'll start with this major fact. 2/3 of adults experience the painful symptoms of eye misalignment, or one study showed 59%. Another showed that about 66%, 65 point something, have eye misalignments, headaches, eye strain, or other symptoms like that. Now, those numbers are huge, obviously, but the bottom part is what really surprises me, that only 1 out of 10 patients bring this up to their eye care provider. So you think, well, gosh, wouldn't they think that eye strain has to do with an optometrist? Well, a lot of times it's headaches. A lot of times it's tied into, tired eyes. Now that should be very optometric too, but they don't think of it that way. They think if it's blurred vision, then we need to check it. Some dry eye, they certainly are thinking much more of our profession, but they're not thinking it from a headache perspective. And sadly, not always from an eye strain perspective either. So we really have to go about that. And the biggest group of this is probably contact lens wearers. They feel like, hey, as I get older, my contact lens should become less comfortable. So that's normal. I'm not going to bring it up. Or my optometrist might take me out of my contact lenses if I bring up the subject. So I'm going to keep it to myself. But the large majority, when you look at this research, it came out and it was a research on 110,000 people. So very valid, was simply they didn't tie headaches and other symptoms of eye strain to their eye doctor. So we got to do a better job of being proactive and telling patients, hey, if you experience these things, we have new technologies, we have new innovations, we have ways to address this. And I am the doctor for you to manage these things that you deal with, because we're not going to see these things go away. We're only going to get more and more issues related to it. Now, there's a lot of factors that do play a role. We certainly know that blink rate goes down by 75%. We're on a digital device, so dry eye can develop. In fact, if you don't blink, you don't pump those meibomian glands, you don't get good oils, you get more evaporation. You don't blink often, you don't pull up the oils from the lower eyelid to coat the eye. And believe it or not, when you get to your slit lamp tomorrow, I want you to look at someone blinking behind the slit lamp. I do this periodically. I don't think of it enough, but when I do, it's always fascinating because our eyelids do this kind of scissor thing. And I'm like, that's a great reminder, which is kind of a debridement and a cleaning of the eyelids. And so that's why we see so much more blepharitis, so much more dry eye, so much more meibomian gland dysfunction. But those pale in comparison to the level of asthenopia, eye strain, and headaches that are out there, which is what we need to address as well. So if you take a look at this data from the Vision Council, that kind of sets the stage for what we're going to talk about today, the impact on adults. 32.4% report experiencing eye strain of the population. More than 1/4 experienced dry eyes. Again, I told you that was going to be a little lower, but that's still a huge number. A little more than that experienced headaches. Almost 27, almost 28% experienced blurred vision. Now that they will bring up to their eye care provider. 35%, actually the highest number of that group, report neck and shoulder pain. How many of our patients think, wow, if I've got neck pain, I need to bring it up to my doctor? Probably not many. So we've got to go a little bit out of our way to look at the most common cause, the most common symptoms associated with asthenopia. The most common symptoms associated with the trigeminal nerve being overstimulated, which is what many of these patients have, and then bring those symptoms up to our patient. Now, I'm going to talk more about that. It seems a little foreign right now to say, why would I bring up shoulder pain to a patient? But when we go through it and we discuss the whole area of asthenopia and the whole area of understanding that effect on patients, I think you're going to find it becomes a very natural way to bring it up. And we're going to get into that. But 57% have 3 or more of the above symptoms. And that's where that number of 125 million patients comes from. You know, I'm always encouraging our profession to do more medical. I do think it's going to be important. It's only going to grow. It's an incredible opportunity that's out there. Dry eye is one of the best spaces. 38 million, while that's big, is pretty small compared to 125 million, which is what we're talking about today with eye strain, asthenopia. All right, imagine I told you that as optometrists with spectacles, we can actually cure more than 50% of all chronic frequent headaches, migraines, frequent headaches, cluster headaches that exist in the United States. You think I'm probably crazy. How could you solve more than 50%? Well, this was a study that was done by one of the top headache specialists in the United States. Carol Nelson is a neurologist that specializes in frequent headaches and headaches as a whole, has patients from all over the country and the world that come in to see her. She was living in Mitchell, South Dakota. She still lives there. And she was noticing patients were coming in wearing glasses and all their symptoms of their headaches had gone away. And she told me this story. She's like, I couldn't believe it. At first I thought, this is silly. These magic glasses can't be doing what I've spent, 13 years as a subspecialist in headaches as a neurologist. And they're actually solving the patients that I can't solve, the ones that were refractory, the ones that nothing I did helped. And at first she kind of laughed it off when someone said they've got these magic glasses. But then after 10, 20, 30 people came in saying my headaches are gone, she said, okay, I've got to look into this. And being a neurologist and kind of like us too, as optometrists, I'm similar. I kind of want to see the proof. I want the research. So she did a study involving 179 patients. The inclusion was simple. I couldn't fix you with everything I know of. They had to be refractory, end-of-line chronic headaches. They had to be frequent, meaning more than 2 per week on average. She went ahead and prescribed prism, so to speak. We're going to get into that in a moment. And her questions were really just 5 categories. In the course of treatment with these glasses, did your headaches increase, no change, decrease slightly, decrease substantially, or basically gone? And if you look at those numbers, 54%, look at the green, of patients reported that their symptoms were reduced substantially or basically gone. 54, more than half the people, you have cured their chronic headaches and no other medication. The average patient with frequent headaches, especially migraines, spends about $5,900 a year out of pocket, not including what insurance covers, on different treatments and remedies, and talk about lost productivity. But 81.6% said there was some positive response to these spectacles. And I want to get into that whole understanding of prism and eye misalignment, because that's what this study was getting at. But I put this presentation first. I know most times these presentations show up at the end, but I put it first to set the stage for, okay, that's pretty amazing data. Let's understand why it's happening. And the way to understand is to look at the neurological mechanism of trigeminal nerve pain. Without getting too complex, we know the trigeminal nerve is the largest nerve in the brain and one responsible for the majority of head, face, jaw, and neck sensations. In fact, you think about that trigeminal nerve, you're going to get effects on the eye, you're going to get effects on the mandible and all through this area. You're going to get effects down lower under nerve and even up into the forehead type region. But if you take the eyes alone, the trigeminal nerve is responsible for your extraocular muscle movement. It's responsible for your blink. It's responsible for the reflex of tearing of your lacrimal glands and your goblet cells that produce mucin that keep your tears together, so to speak. It's all responsible for meibomian gland expression indirectly because of the blink. It's responsible for your nerve function, your neurotrophic supply to the epithelial cells, and nerve restoration or maintenance. Those are just partial lists of what the trigeminal nerve does. It's the most important nerve when it comes to the eye especially, but also the head, the face, the jaw, and the neck. And now you can understand why patients get neck stiffness and shoulder issues if their trigeminal nerve is involved. And that's not too far of a reach from the eye to the shoulders or to the neck. They're kind of in that same vicinity. Well, they're the same nerve. So we understand that whole thing kind of plays together. Now, one thing I wanted to spell is trigeminal neuralgia. That's a term that we've heard of for many years. And trigeminal neuralgia, while it does involve the exact same nerve, is very different from trigeminal dysphoria. That's what leads to asthenopia. That's what leads to these chronic frequent headaches for a fair percentage of patients. Not all. Some have other reasons for headaches. But trigeminal dysphoria being one of the more common ones is definitely the big cause for eye strain or asthenopia. And so the difference really is that in trigeminal neuralgia, that's characterized by this very severe, sudden, but usually just kind of a quick tinge. Some people get occipital neuralgia, where they turn their neck and they get this sharp pain up the back of their skull. That's another form. It's called occipital neuralgia. But trigeminal neuralgia is what we're getting into. The trigeminal nerve is an excruciating facial pain attack on one or more of the cranial nerve 5 branches. You get this severe reduction in the quality of life in these patients because they're always worried about how often it's going to happen. It really debilitates them when it does. And it's either idiopathic, classic, or secondary. Now, what we're going to talk about today, and you do need to know the difference between the two. Trigeminal neuralgia usually goes to a neurologist or a pain specialist. Trigeminal dysphoria goes to the optometrist. This is really our world of dysphorias based on asthenopia. It's a condition that triggers dry-like symptoms. And so that's what brought me into this whole space. So I first learned of this technology 11 years ago. And I'm always learning. I mean, I've been at my dry eye clinic now, especially for over 2 decades. And I'm proud of my dry clinic. I was in a panel last year with 2 well-known ophthalmologists who have dry eye clinics. And they asked them, how many Sjogren's syndrome patients do you have that you manage for dry eye? Because there's some drugs coming out for that in the future. And the first well-known ophthalmologist said about 30, 35. And the next doctor, also I respect both of them a lot, said about 60. I have over 900. I was like, if I say this, they're not going to believe me. But I had to be honest and say, we just did an ICD-10 kind of data mine. We were looking to see how many patients we had that had true diagnosed, clinically present Sjogren's syndrome, KCS, and the number at the time was about 820. And I know a year later, we're probably maybe 850, 880, but still, it's a number that's very disproportionate. And that's a small percentage of the dry eye patients. But a lot of that has come from trial and error, making a lot of mistakes and learning. And here's one that I really was way off in. So this guy named Dr. Kroll, an optometrist, calls me. He says, Paul, I know you have a pretty good dry eye focus to your clinic. And he goes, you probably have some patients who you can't fix. And I said, yeah, unfortunately, I got a lot of them. I don't know how many are going to fly to South Dakota where you live. He goes, no, I will come in to your clinic. If you can line up 12 patients whose signs you might have improved, but you can't resolve their symptoms, or you've never been able to improve symptoms at all. If you can line up 12 of those, I will fly myself to Lexington and I will spend the day with you. And I think I have a solution. I said, well, this is pretty cool. One, I'm open to solutions. I can't fix these people anyways. Number two, it's a colleague. I love that, whether it's optometry or an ophthalmology colleague, I'm always open the door. And so they flew down. I was able to line up 10 patients that day. And the first thing he starts doing, he said they all had dry eye-like symptoms. Well, that's the only reason they'd be in my clinic. And he starts measuring cover testing. I'm thinking, well, this is interesting. He starts measuring eye alignment. I was thinking, man, how soon can I get this guy back to the airport? Because this is so foreign to me. I don't know anything about this binocular vision stuff, but I want to learn. So I listened, watched, and this is the most amazing thing. Out of the 10 patients, 9 had misalignment issues causing this phantom dry eye that I couldn't fix their symptoms. 9 out of 10. And I sat there in awe and thought, this is absolutely incredible. Because he didn't ask me to line up patients with eye misalignment. For one, I wouldn't have even known how to look for that. I guess cover testing. I guess today I do. I have patients look in the distance and I do a cover test. And if the object moves, with my hand going to the right, then to the left, then that's exophoria. And it's usually worse up near convergence insufficiency. So I can diagnose it today by a quick cover test. Back then, I had no idea. And he put some prism in the glasses of all 9 of these patients. And I kid you not, he improved all 9. Most of them, he eliminated their dry eye that I'd been working on for years. And I thought, man, I've got a lot to learn. I said, what is this called? He says trigeminal dysphoria. The trigeminal nerve gets overstimulated by this misalignment. The brain thinks it's looking here. The eyes are actually looking here. In fact, 3 of the patients had traumatic brain injuries. Makes sense. The majority of the other, that's the way their eyes were aligned. And it's very common. In fact, it's the number one reason, one of the number one reasons for non-responsive dry eye. I'd say it's number 3 in my clinic. Nevertheless, he went ahead and corrected the eye misalignment. All their symptoms disappeared. And I thought, man, this is amazing. What happens with misalignment is you're constantly compensating. So you have the sustained effort to realign. And the brain thinks that you're looking here. Your eyes are actually looking here. So they're constantly moving. And guess what gets all of the brunt of that overstimulation? The trigeminal nerve. It has an efferent and an afferent pathway. So it's naturally going to go back to it. And that overstimulates that nerve. And in fact, that's why patients get headaches, dizziness, dry eye sensation. They don't really have dry eye strain, neck and shoulder pain, trigeminal nerve, and even photophobia. So my mother-in-law told me I can share this story, and wonderful lady. And after a few years, I noticed she had, when I was first with my wife, there were times, one time we were going to go visit, and we couldn't go. It was only one time, but she had a severe migraine. And she had to not lock herself, but close the room, turn off all the lights, all the sound. And what you're doing when patients do that with frequent headaches or migraines, they're actually decompensating the trigeminal nerve. No stimuli, it recovers. And then they can get back to life until it gets overstimulated again. And I never put that together. Sadly, about 3 years ago, and I should have fixed her sooner because she really is, and I like my mother-in-law. About 3 years ago, I said, do you get headaches still? She goes, all the time, like 5 to 6 a month. I said, eye dryness, yep. Shoulders, neck hurt, yep. Light sensitivity, sometimes. I said, oh my goodness, I think you have this condition. I didn't want to tell her how long I've known about it. I said, let's get you tested. Went ahead and tested. Sure enough, she's 3 diopters of exophoria at distance, 10 at near. Talk about convergence insufficiency. So I got her a pair of contoured prism glasses. I asked her this past year, how many headaches did you have last year? She said, I think just 1 or 2. She used to have 5 or 6 a month. It's all based on that compensation overstimulation of the nerve. And she had 5 of these symptoms, and I never even dawned on me. Today, I kind of pick up on it a lot quicker, and I did. Now, a lot of people used to think asthenopia or eye strain was simply because of the fact that we were dealing with the muscles wearing out. But in actuality, that's not the case. Our muscles are about 100 times as strong as they need to be. And even in one study, 60 times as strong. So the mechanism for prolonged activity without fatigue is already in place, and it really can't happen. So I think that becomes very important in terms of where we're at. There's some really good comments here on the chat. I'm going to answer some questions. In fact, right after these next 3 slides, they're all tied together. you look at extraocular muscle motility in terms of motor unit strength, our ocular rotators or EOMs, have certainly a significant rotator composition. I mean, the muscle fibers per neuron is at a low enough level that allows for strength. Believe it or not, that's what that combination is. If you look at the phasic bursts, they're well over 600, which is way higher than, let's say, a skeletal muscle. Tonic is more than 200 compared to about 50. And probably the most important thing is fatigue resistance, as I showed, is about 60 to 100 times the reserve of what it would take to fatigue an extraocular muscle. So it's not from muscle strain. I know a lot of you probably know that. I didn't dawn on me many years ago till I started doing the research. It really has to be some other issue, and it's the trigeminal nerve gets overstimulated. Let me hit a few questions here because there's some really good ones. This is a good time to grab a few of them that come in. Okay. Do chiropractic adjustments help these patients? Oh, this is a really good question. Marina, good question. I'll tell you why this is so good, because that is, if you start asking patients, have you seen a chiropractor who have trigeminal dysphoria issues? I will tell you that I believe 80% of the time they'll say yes. Yes, I've been trying to get things adjusted in my neck. I've been going for years. And while it may help for a short period of time, and it does help to some degree, it doesn't resolve it. And the reason it doesn't resolve it is the cause is where the brain thinks you're looking, the proprioceptive component to where the eyes really are, and that misalignment between the two overstimulates the trigeminal nerve. And there's nothing, well, not that I'm aware of anything chiropractors can do to affect the trigeminal nerve, but they can help temporarily with some of the muscles that do get involved from overstimulation from the trigeminal nerve, but not the cause. The only thing that can adjust the cause is when we can get their eyes aligned so that the trigeminal nerve doesn't overstimulate. And then, like my mother-in-law and many hundreds, if not thousands of patients now that I've seen, they go from 5 or 6 headaches a month or a week to 1 or 2 a year because you've solved that trigeminal issue that's there. Thank you. Nice question. Let me go into the next area here too. What we call proprioceptive conflict is a different study again. And I'm going to get into how to calculate prism because it's not something I do well. And there's many different ways. There's Percival's criteria. There's all these others, Von Graeff. There's a lot of, or Von Graeff, depending on how you pronounce it. There's a lot of different subjective ways of measuring. I'm going to definitely get into that. But also, I'll caution you by saying they're not always that accurate because they're subjective. And so don't, it gets frustrating sometimes when you try to measure. But that's what I did 10 years ago, a lot of. When I was first learning about this and trying to solve some of my dry eye patients who didn't have dry eye, that played a role. So are you checking for exo with or without correction? I do with correction. And I think that's really important. And the person didn't put their name, but it's really a very important question. And the reason being, that with 4.5 diopters, for example, of myopia, a myopic lens has a built-in base-in prism. Just remember the shape, it's like a diamond like that, your myopic lens. So you get a base-in prism automatically. So a high myope has a diopter base-in prism if they're like -6 or above. So you have to do it with their glasses correction in order to achieve the ideal prism need that's in place. Some people use the fixation disparity test by Ron Mallett. That's a great suggestion. Others use Maddox rods. We're going to get into more things that can be utilized in this space as well. So proprioceptive conflict is another area of research that's becoming well known. It's interesting. So let's look at these symptoms: headache and neck pain, pressure and ache, dry eye sensation, fatigue, light sensitivity or photophobia, significantly worse when using digital devices. Well, I believe they're the same condition. I think we've called this thing eye strain, asthenopia. We've called it many different vergence issues, convergence insufficiency, and that is true. It is that. But it's also proprioceptive conflict where the brain is perceiving something and the eye is, and there's this constant conflict and stress between the two. And it fascinates me how these are two different studies. The symptoms are pretty much identical depending on which one you look at, because I think they're tied in together. The most common complaint of patients with asthenopia is tired eyes. No surprise. That's by definition what asthenopia is: eye strain, tired eyes. But in normal health, one doesn't really experience eye fatigue, that the muscles don't tire. We talked about that. In fact, we do over 170,000 saccades in the course of one day. So patients who experiencing this overload of cortical input, there's consequence to that stress and that tiredness. And then in extreme cases, it shuts down. Now, keep in mind, there is a threshold. Every patient has a threshold for pain levels, and it has been known for years. It's very variable. Some people can have convergence insufficiency, which I do, and I don't remember having headaches for years. I get an occasional, maybe sinus headache I wake up with once or twice, maybe once a year, every few years. So I can't say I don't get headaches, but I don't get these that I should when I have convergence insufficiency. So my threshold must be a little higher. And some people get them immediately and all the time. Others just get eye strain and eye dryness and some of the other sensations that go along there. 76% of workers say they feel tired at work. Maybe the number is bigger than we think. 53% feel less productive. 44% have trouble focusing. That could be many things. So how do we reduce stress? The answer is really prism is the solution. And you guys kind of got that. I saw the answers already coming up from some of the questions where you guys put that together. So the proprioceptor fibers innervating the extraocular muscles tell us where the brain thinks the eye is looking. And then there's an afferent feedback to the brain that says, okay, here's where the eyes are looking. If that feedback is off from fusion issues of misalignment, that's why patients who've had traumatic brain injuries, concussions, trauma of car accidents, or military, something like that, you do see a lot of misalignment of the eyes, and they get a lot of trigeminal dysphoria, headaches, and other issues. These proprioceptive signals are transmitted through the ophthalmic branch of the trigeminal nerve. Guess where that goes? To the corneal branch, right to the eye. And that's why they get this dry eye sensation. Now, they might get a little dry eye too from lack of blinking, some meibomian gland dysfunction, but these are the people where you treat the dry eye and their symptoms don't really go away. These signals play a large role in the stimulation of that trigeminal nerve through the efferent pathway, resulting in symptoms that are associated with the term trigeminal dysphoria. So it is the link between the two fibers, afferent and efferent, and where they come in. And because the eye is so innervated, that's the link to dry eye. Now, it's not the majority of dry eye, don't get me wrong. The majority of dry eyes, because their eyes are dry, their meibomian glands, their mucin-producing goblet cells, their lacrimal glands, accessory lacrimal glands are not functioning as the level they should. But there is a large subset that are not dry eye that present with dry eye symptoms and neck stiffness and headaches that present later in the day or worse on the computer. And they also talk about dizziness and photophobia and a few other things that can go with it. And those are the ones that are caused by the trigeminal dysphoria. And that's the link between dry eye and headaches for that subset of the population. It's the cornea, the EOMs, and the trigeminal nerve that link those together. And the ophthalmic branch is one of the larger branches, so there's no surprise that dry eye would be the sensation. I will tell you that once a day in my dry eye clinic, I'll have a patient who has this trigeminal dysphoria. And I'm like, no wonder nothing worked. No wonder your cyclosporins and your lifitegrast didn't do anything. You had a treatment, their MGD improved in the office, but their symptoms never went away. And again, that trigeminal nerve leading to the ophthalmic and then the corneal has a very significant number of nerves, more than almost anywhere in the body. So I got this question in the chat and the Q&A a lot. How do you routinely perform and determine if a patient can benefit from prism? How do you measure prism? And you can feel free to put in the chat what you do. Some use the fixation disparity test by Ron Mallett. That's a good suggestion. Saw that come up a couple of times. We fit a great deal of vertical prism, which solves so many issues. Wonderful, Harvey. Great comment. Keep in mind, it's not always exophoria and convergence insufficiency. Vertical misalignment can lead to the exact same trigeminal nerve overstimulation. So Harvey Amato's spot on with that comment. That is exactly right. Do you think the trigeminal dysphoria is the cause behind post-LASIK PRK dry eye? Wow, Frederick, I've got a case on that right at the end. You just got the answer to my third case. So let me cover that when we get to that case. But I think that is enormous, an enormous cause of this chronic post-LASIK dry eye that isn't caused by LASIK. That's very insightful. Can't wait to show the third case. You're just way ahead. What are your thoughts on vision therapy for these patients? Love vision therapy and the combination. In fact, some of the best patients, those who use technologies like contoured prism, which is a newer technology that's available. And some of the most successful are the ones who also do vision therapy at the same time. where they have these multiple options for patients. They can give them the impact they need with the spectacle correction at first, then work on trying to permanently correct it. Back to Frederick's comment, if you do post LASIK and you have both eyes at plano and your goal was to get out of glasses, and now I got to put you in spectacles to correct your prism issues, that patient will want some vision therapy if it's available. So there are times where it makes sense. Then other patients will say, I just want the spectacles. I need to resolve these headaches. Like my mother-in-law, actually my niece had a concussion. She's a varsity soccer player, very good player for a big school, had a concussion and couldn't get through her exams well. She's a 4.0 student and she had to come down from Michigan down to Kentucky for me to do a test on her to get her a pair of glasses so she can finish her exams. And last I heard, this was this past Christmas holiday time, she did fine. Point being that not just my family, I have about 1,000 patients too, but the point being, these are patients where they just wanted the quicker fix to be able to get where they are. So your thoughts on vision therapy for these patients is really a good call. These go hand in hand. These are very much synergistic treatment options. One can address sometimes vision therapy, the cause, and get it better. The spectacles, of course, give you the immediate response that you need, and for some patients becomes the ultimate treatment too. We'll get back to some more questions just so I stay on time. So eye mislead alignment has previously been tested by cover testing, usually with a prism bar, Foria's fixation disparity. You see the Maddox rod up there, Percival's criteria, where you calculate 1/3 of the disparity need, Sheard's criteria, etc. I always laugh at that. Who's that comedian, Brian Regan, who has a skit on optometry. It's pretty funny where he goes in to see his optometrist and he's just panicking because he can't resolve the 20/20 line. Both of the lenses look the same. And then he talks about the von Graefe testing where the doctor asks him to tell when the two lines line up above each other. And he's like, now. If you ever haven't seen that video, it's kind of worth seeing. And but it's a great kind of spoof, but it is also on, the fact that it is difficult for patients to pick up that exact endpoint that's there. So, the process even today is you find the unmet need, you use some sort of measurement. Subjective is what I used for years. Now there are objective, repeatable measurements that take about 2 minutes. You put the patient's chin in there. It separates distance and near as far as disassociation between the eyes, and then corrects for prism. It measures it vertical, horizontal, near, far, spits out the answer. And then you use that to create your contoured prism or your prism correction that's necessary. In fact, today's real-life measurement machines for binocular vision take into account heterophoria, Vergence conditioning, binocular or peripheral fusion, fixation disparity, accommodative convergence response, alternating monocular fixation disparity, central fixation. I don't even know some of these. Peripheral and central vision measure is an objective, repeatable, and accurate at both distances. And I think that's by separating them out, you do get quick measurements. And so for me, while I had used von Graefe Maddox rod cover testing to try and figure out best prism, and I did that ever since that visit from that Dr. Kroll 11 years ago. So I did that for about 6 years, solving a lot of patients, and then moved over to these measurement devices available today that take 2 to 3 minutes and do it all for me. But either one works as long as you're good at it. This is just, for me, the way to go, because I get my pupillary distance, I get my exophoria measurement, I get the vertical. Someone earlier, I should give credit to whoever it was, I have to look at the Q&A earlier, had that terrific comment on the importance of vertical prism. I think it was Harvey, not mistaken. Let's go back again. That was very important because that itself can give you these same symptoms. The measurement quality index was high, meaning I know the measurement was good. The patient kept their position. And for me, what's really important is some people ACA ratio, which allows for how much they can accommodate for this. But the actual value is important. If it's 0.4 base in, I just go off of that. These devices now have so much AI in them. They feed back millions of cases that they know exactly what prism should be used and where. And it does give you your far and your near to be able to know if you can get away with just pure prism or you need a contoured prism. Over 90% of patients do need a contoured prism. And I want to emphasize, a small prism have big impact. You can correct literally 1/4 of a diopter, prism diopter in each eye in some patients, and it changes their life. Most patients, it's a 1/2 a diopter. in each eye, some maybe 0.75. Usually I don't get much over splitting 3 ever in patients, but there's no correlation with those who need a diopter of prism in each eye versus those who need a half a diopter. They still have the same amount of symptom improvement that exists. Small horizontal prism corrections make a huge difference. Verticals make a huge difference. And those abilities to test those alignments become critical. About 10% of the patient population can have uniform prism needs at distance and at near. That is, if you were to measure their distance prism requirement, let's say it's 4 diopters base in and near is 4 diopters base in, it is somewhere around, depending on which study you look at, 6 to 9.5%. So let's say 10. The other 90% have a greater need up close, greater prism requirement. There's more convergence and sufficiency taking place. So one of the newest innovations to come out is a contoured prism. It doesn't go just, an increase of 0.75 at near. It's not a sharp turn. It is a contoured progressive change as you move from prism in the center at distance to inferior prism, and your intermediate changes a little along the way too. That's what contoured prism is. So it's very beneficial for 90% of the patient population. Contoured prism does increase by a standard 0.75 base in that takes place inferiorly, but as you can see by that blue just above it, right in here, it kind of blends into that. It doesn't go from 0.75 to 125. It goes immediately, that increase over that period of time is including in the intermediate range, almost like a progressive lens, so to speak. Do they work? This is a recent study that looked at 250 patients in one study, 400 in the other. And this looked at headache improvement, 83.4%, neck pain, 78%, discomfort with computer use, 82%, tired eyes, 84%, dry eye sensation, 80.5%, light sensitivity, 79%, and dizziness, almost 90%. I also find that patients who are younger, children, teenagers who have eye misalignment have much more dizziness. And then sometimes senior citizens too. I had a patient not so long ago who, when they were leaving the room, the husband came up to me at the end. He said, "Dr. Karpecki, I've got to thank you so much." After his wife had left, he came back and said, I shook my hand. He said, "I can't thank you enough." I said, "Well, great. What do we do?" He said, "Well, my wife hasn't driven in 30 years from dizziness. 30 years. She had her license. I've driven her around for 30 years. We're retired. I'm in my late 60s. Ever since you've corrected this issue," she drives all the time. He goes, "I just sit in the passenger seat. I'm hoping for the next 30 years. And I laughed. But the point was, dizziness can come up later too. No, I mean that it doesn't there as well, but I do see it more in children. It also improves reading speed. Reading speed is improved by 70% in patients who had contoured prism in this double-blind parallel arm speed testing before and after. A control group that had a pair of normal spectacles, and then those who had a neural lens or contoured prism is what that should say. And that was statistical, a P of 0.03. Remember, 0.05 means you have a 95% likelihood this wasn't random. So this would be 97% likely this isn't by random chance. So high statistical value there. The other big thing is, I really realized this 11 years ago when I started prescribing standard prism. Patients they called it prism creep, or patients eating prism. Does it happen with contoured prism? And the answer is no. In fact, studies show that in using a contoured prism, the reason why you get the creep is because there's more of a need for prism correction at near. And the body adapts to the distance quicker. And then at near, it needs that extra amount. So you start with half a diopter base in both eyes, because that's what you measure. Then you go up to 0.75, and then you go up to 1, and they keep coming back. And I found that happened in my personal experience in more than 50% of the patients I treated with standard prism. In fact, I asked Carla that today, knowing I was going to do this very unique presentation tonight. And she said, I think it was at least 2/3. So she's one of my people who run my clinic. And I said, wow, that is up there. So somewhere between half and 2/3. And I said, how many have we had with now these contoured prism? And we couldn't think of a single patient. So after the first follow-up visit, at least 1 year after initial prescription, the average change in prism in neural lens patients is really 1/3. Not even, enough to me a full correction. 45% and no change at all. It's 1/10 of a change over longer periods of time, second follow-up. So you're not going to see a significant creep, and this paper was published on that in this patient group. Okay, let me take a few questions, and then let me do 3 cases for you that I think will help tie this in a little bit better. So let me jump over to, let's hit the Q&A. Oh, that's a great question. So Michael's been at one of my lectures. Thank you, Michael. Great question. I said, I heard you speak at a lecture that if you gave patients base in prism, actually not necessarily 2, that's I might have said that then, but I'll refine my answer today. If you gave patients a 1/4 diopter or a 1/2 diopter of prism at near RX, they would be better off than if you simply didn't. Yes, from an eye strain perspective. Now, if they're esophoria, that wouldn't apply. That really wouldn't help. If I do my cover test and the object, especially at near, moves against the paddle, that's esophoria, then that patient is not going to benefit even from a 1/4 or a 1/2 for sure. But yes, if they're ortho, or especially any ESO or any convergence insufficiency, not only, to be fair, not only would they feel less eye strain, asthenopia, and feel more comfortable. This is the unfair part. They probably could never go somewhere else and get regular spectacles again. They'll have adapted to that tiny bit of relaxation prism in that patient population, that it would be very hard to go to a non-prism lens, even if it was just 0.25 or 0.5. So you would lock the patient in, but you probably, out of ethics, should tell them that wherever, if they don't go to your office and go somewhere else, that would be very important that they measure the full prescription in your glasses, not just the refractive error, because they're going to be searching everywhere for glasses that were as comfortable as the ones you provided. So yes, Michael, I still stick by that, but not one prism diopter necessarily in each eye. That's a little high, unless they warrant it, unless they measure for it, then definitely. But for those who are low amounts, even a 1/4 or 1/2 in each eye is probably sufficient to really make a difference for that patient. So that is true. I learned that actually from a doc who said, I put a 1/4 diopter or a 1/2 diopter prism in each eye. Patients can never go anywhere else. I thought, well, what happens when you stop practicing, or what happens when they search or they move or something? He's like, well, they'll have to come back. I thought that was not a very good answer, but it stuck with me because there was something to it. And now that I've really studied this area a little more, there's something to that. Okay, there's a question on the trigeminal nerve stimulating tear production, but stimulating the trigeminal can cause dry eye. What am I missing? Nice question, Philip, because it is a little bit confusing. So if you look at things like neurostimulation devices, drops, or devices that are out there external that work on that parasympathetic pathway, they're called nicotinic receptor agonists. And what they do is they trigger the parasympathetic pathway that then goes to the trigeminal nerve ganglion. You're right, not all the way to the nerve, but to the ganglion. And then that causes a stimulation that produces tears. So that is treating patients with dry eye. Patients with trigeminal dysphoria have a dry eye sensation because the corneal nerve from the ophthalmic branch of the trigeminal nerve innervates the cornea. And that overstimulation on the cornea over time feels like, they describe it as dryness. Some describe it as itching, but that's rare. Dryness, irritation. It's not dry eye, though. You test these patients, you use even high technology like osmolarity and expression and fluorescein dye or lissamine. You don't see any. I don't use lissamine anymore. I use a number 15 yellow rattan filter, and I could see conch staining even better with fluorescein. But the point being, I use all those tests and they're all negative. They don't have dry eye. They have a dry eye sensation. So it's not that the trigeminal nerve causes dry eye. It's a dry eye sensation from the nerve stimuli. And those who have dry eye, by stimulating the trigeminal nerve in that pathway, remember there's an efferent and an afferent. It's the afferent backwards that causes the eye strain. The efferent outward, I know it sounds so crazy, but the efferent outward that causes the stimulation of tears. Goes through tears and then comes back. Will prism provide a crutch in the long run, and will it turn? We will have to increase it slowly over time, which I've seen in some cases. Christine, a wonderful question. That's the prism creep we were talking about. And the answer is yes. If standard prism for all but about 10% will actually over the long run increase because they're needing more if they have convergence insufficiency, which 90% have, because they're needing more up close. And that, so what you have seen in those cases, Christina, is exactly right. It's what I've seen. Contoured prism eliminates that probably for 98% in my, actually about 100% of my experience, but they say around 98, 99% of patients. The intrinsically photosensitive retinal ganglion cells may be a player in headaches and dry eyes. Can't argue that either. In fact, there are other factors that play a role. Patients with migraine headaches that are not related to the trigeminal nerve, but have other category effects, just think about the aura. That's an ocular manifestation that these patients with classic migraines get, yet there's no connection that we're aware of to the trigeminal nerve in that particular condition. Now, you could have both, that's possible, but not in of itself. So, Chung, you're 100% right. There are other pathways. In fact, while this actually solved more than 54% of the refractory headaches, that means there still was another percentage that didn't solve, that not related to the trigeminal nerve. How frequent is the PD off using a pupillometer compared to the neural lens? Neural lens is extremely accurate, Brad, when it comes to that PD measurement because it's measuring it real time, and it's disassociating the peripheral from the central images so that you do get exact measurements of each one. So it tends to be accurate. That being said, it's usually not a big difference from a pupillometer. Those tend to be pretty accurate too. And on occasion, there'll be a little variance, but not in my experience a lot, at least not to the point where any of my staff have come to me and said, I'm getting two very different measurements. Can you tell me which one to use? I've not seen that. Okay, we'll come back to a few more questions. Let me hit a few cases that might tie this all in. All right, young patients, most common trigeminal dysphoria issue or symptom in younger patients. Do you remember what it was? It was dizziness. Now, she has headaches at a 4. But she has dizziness as a 4. I do see that a lot, headaches and dizziness. Convergence insufficient. She is an intermittent exotrope, so I wasn't sure if that was going to help her. Worn glasses since the age of 11. They've helped, but she still complains of headaches and dizziness. Now, when we did the testing, she said 3 on neck stiffness, 2 on digital device discomfort, computers at the time, 4 on tired eyes. That's up there too. Dry eye was not much of a factor, and light sensitivity was a 2. And you can see here she's got a little cylinder, slight near spherical equivalent near plano, but she measured 1.6 base in. If you look at her exo at distance, it was 3.1, but look at near 10.2 exophoric near. Talk about convergence insufficient. We looked at her questionnaire. I do like these lifestyle indexes for these patients because you see it readily. And obviously headaches, tired eyes, and dizziness. Younger patients, I see that category of headaches and dizziness more often. Older patients, but not without exception, I tend to see more neck stiffness, dry eye, photophobia, and a little less of the dizziness, but still the same amount of headaches. So the patient reported with these contoured prism glasses much clearer than before, despite the exact same prescription. I did not change. The refractive error was not changed at all. So actually, I wasn't my patient. So, but the refractive error isn't changed, plus 50, minus 1, 96 stayed the same, and the one at minus 125. But I have seen patients say, this is the clearest my vision has been. It's not clearer, it's just more relaxed. It's less strain, less issues, but they will describe it sometimes as clear. She makes fewer mistakes when taking tests. On her reports, her headaches have lessened significantly, and she no longer experiences dizziness. Not uncommon to see. This is another very common patient type. I'm just going to give you 3 common ones I see. The second one is a 42-year-old female coming in because of, we thought, presbyopia. But she mentions headaches. And I used to dismiss headaches a little bit, or at least say, well, that's something you need to get checked. But now I'm getting to be more into headaches. If you have headaches in the morning, that's often sinus headaches. If you have headaches late in the day, that's asthenopia, trigeminal dysphoria, that's eye strain related. If you have headaches that wake you up in the middle of the night, seek a neurologist. That's a pending aneurysm, a brain tumor. I mean, if they truly wake you up in pain in the middle of the night. If you wake up with them, those are fine. Those are sinus headaches and things like that. Your worst headache, your first headache in a certain location are worth investigating, and those that wake you up at night. So it is important to understand headaches because we're going to get these coming up more and more. Light sensitivity or photophobia, tired eyes just never felt quite right. Now, one thing I've seen in a lot of patients who struggle with their progressive lenses is because they do have eye misalignment issues. They have exophoria, convergence insufficiency, and they can't. One, those are people who usually need presbyopic correction sooner. And number two, they have more difficulty adapting to progressive lenses. So if you have a patient who has problems adapting, think about the prism need. That can solve it for this big patient population. Her lifestyle index was typical of that: light sensitivity, dry eyes, tired eyes, headaches. RX with progressive was Plano with a 150 add. So this is not uncommon. Younger patients with exophoria and especially convergence insufficiency, because they can't, remember, we accommodate by our pupil getting smaller, by our eyes turning in, and by our mechanism of accommodation within the lens structure. If one of those is out of balance and your eyes don't turn in, convergence insufficiency, you experience presbyopic issues sooner. So a 150 in a 42-year-old is not uncommon if you have significant convergence insufficiency or if you have significant exophoria at distance. And look at her near 9.48 exo at near, 3.4 at distance, totally makes sense. 1.5 base in prism was prescribed to this patient in a contoured prism. She described relieved and thrilled with the new correction. One headache in 14 days, previously had headaches daily, she said. Vision seems, her quote was natural, has more energy, can concentrate more, her eyes feel better. She takes fewer breaks. She feels like a weight is lifted off her shoulders. Interestingly, shoulders is a common symptom. Finally, someone's listened and understood my problems, but I think you'll get a lot of that. And then Frederick said, hey, what about your post-LASIK patients? Man, it's like he knew my presentation. Slide case 3, 37-year-old male, had LASIK 5 years ago. Says, I wish I'd never had it. The moment I had it, literally within the first week, I have severe dry eyes. They've never been better. I've seen 4 doctors. I've spent more money on dry eye treatments than I spent on LASIK. That's what he told me. And I've been treated with everything under the sun. Turns out he was significant convergence insufficiency with exophoria. So he was like about 3 in 10, I believe. I'll look at him too. He's worn glasses since age 9. I asked him, did he ever wear contact lenses? He said, no, I started getting so much dryness with contact lenses. Fred, you probably know the answer to this case. What happens when we have myopic prescription, and right now he measures Plano, plus a quarter post-LASIK, Plano in his other eye, but he measured a 1.3 base in neural lens measurement. And his main things, you can see computer discomfort's a 5, dry eye. But he said, I do get headaches. I do have neck stiffness. He never even mentioned those when he came in until we gave him the lifestyle index. He mentioned a little light sensitivity and occasional dizziness. When you have a prescription of minus 450, and look, he's 3.8 exo at distance, 9.1 at near. 4.5 diopters gives you a little bit of base in prism automatically. Look, his osmolarity was normal. He had trace blepharitis, collarettes. Look at his expression. Perfect olive oil, almost perfect, a little thick, but still clear, nice. No corneal staining, adequate tear meniscus, no conjunctival staining. His breakup time on Carograph was more than 10. I said, dude, you don't have dry eye. And he goes, I don't have dry eye. I've been treated for years. And he goes, I'm not on anything right now because nothing worse. I said, can you bring your spectacle lenses in? He brought in his spectacles. He had them still, minus 450 DS. And guess what they had in them? A diopter base in prism. So what happened is the combination of his myopia and the base in prism gave him all the correction he needed at distance and near to compensate for his trigeminal dysphoria. When he had LASIK, there goes his prism. And he had all kinds of symptoms of dry eye and headaches. Thought it was his LASIK. He didn't have any dry eye. When glasses were eliminated, his TD symptoms appeared. He now wears Plano. Poor guy who tried to have LASIK to get out of glasses. He now wears Plano RX. Very soon he'll be in presbyopic lenses, so that'll work. He has no symptoms. He's glad to be in glasses, he said. It solves all these issues. So a small amount of base in prism will produce a noticeable change in the relation of fusional demand and reserve. So the average patient may require very limited amounts to restore comfort. You know who said that? Irv Boyer 75 years ago. This guy was so far ahead of his time. I should have paid more attention. you read his book, he knew about all this stuff that took me a lot of research to put this presentation together and rely on people much smarter than me. He already knew it all, and he was right. Small amount of base in will produce a noticeable change in the relation of fusional demand, and that applies to most patients, except those maybe with dysphoria and other issues unrelated.